be. But there are some forces afoot driven by technologies and business that could change that. So I think this is a time of change. But our goal here is to improve population health with outcomes and outputs that people actually care about. So when you hear me talk about informatics, I'm talking about how we help a health outcome. I am not talking about the IT guys in the back room and playing with cool bells and whistles and bright, shiny object devices. I'm really talking about, so what? Do these things give us anything that matters? Well, in my generation, this guy Bob Dylan had a wonderful song, "The Times They Are A-Changin'," and I think that's the theme of today. It's a theme that I want to weave into this talk. So let's talk first about forces that are shaping public health. We have this national health challenge that the professor just mentioned. We have this information assault, this information environment that we live in. We have new partners. We have e-health and we have e-public health. So what's this national health challenge? Most of you have seen this curve or these kinds of data in one shape, form, or another. I just bring up one graphic to make the point. If you look at life expectancy at birth, the vertical axis, and plot that against total expenditures of health per capita, and look at developed countries, the developed economies, the 50 largest developed economies, you get something like this. And what does that say? It says that cluster there in the middle. Normally I like to run up and point at this, but I can't do that. So think of that cluster there in the middle. Okay, those are a lot of the European countries. And it says that for about $3,000 to $4,000 a year per capita, they get maybe between 79 and 82 or 3 years of average life expectancy at birth. Okay, so as a population health metric of how is our health investment doing, that's kind of a measure of where a lot of developing countries are. And where are we, the USA? Well, we're that little dot way out there towards between $7,000 and $8,000 a year. And notice that we're down lower. So what's that tell us? It says that we pay roughly twice as much to get less. That's one of those drivers, right? Health reform is driven in part by that reality. We pay too much, we get too little. Too many people don't get care. Too many people don't get access to care. And those of us who get it pay a lot, and our outcomes aren't as good. There's a problem here. So that's a driver. And it's a driver that's not just of the health system, but it's a driver of us, the public health system, because the pressures, the financial pressures, I would argue, that are being put on the healthcare system to move to value-based purchasing are moving towards us also. Our accountability, our need to produce value to the public in terms of population health benefit is critical. Part of the health reform equation was built around the premise that public health efforts would pay off. If our population health work in terms of prevention and early detection and intervention of diseases that could cause morbidity and mortality, if our work pays off, then we reduce the national health care expenditures. We help push length of life up and length of healthy years up. So this is a really important curve to kind of keep in mind. This relates to us in public health also, not just the healthcare guys. So I ask about the cell phones. Why? Well, because we live with these devices, and a couple of things. One, we live in the 24-hour news cycle. And I know every one of you in an agency, if you've faced any kind of an emergent problem, the public now wants to know what to do from you. Right? So what we've come to, what these devices really, in my view, tell us is that we each want to know now our answer to our question, and we want to know it specific to where I am, my time and place. The old days of disease trends that were 3 years old, the old days of mortality data that's 2 or 3 years old, the old days of information that was national, or even more recently, statewide, it's passé, right? The public expects you can tell them what's going to happen in their neighborhood tomorrow. When we have a flu pandemic like H1N1, what happened? Shoot, health officers are being asked by their governor and their mayors, do I close these schools in this county tomorrow? That's the public expectation. Is that a driver for change? Is that a driver for improving quality of the services we in public health deliver? I think so. This 15-second rule refers to something that Apple Corporation uses in their development. They know that if one of their applications doesn't give the user an answer within 15 seconds, the user walks away. That's their outer bound of giving you an answer. Now that means the application probably has to be talking to you within milliseconds or you walk away. But that's our reality, right? And we're all living in it. It's a driver. I use this diagram, this flower, to talk about another driver, health information exchange. On the big information landscape, this has been around for well over a decade. The idea that now as we automate our healthcare data, it should move with us. But when we talk about that, what's that mean? Well, it means all these different parties are partners in that information exchange. And this is complicated, and it is not resolved, and it impacts you. It impacts you because your programs that have to interact with any of these partners are now interacting with partners who have some automated data and some not automated data. And this is a struggle, because guess what? Nobody's paying us in public health to be able to handle that diversity of an environment. And in fact, all the spending under meaningful use, the era high-tech spending, didn't pass much, if any, money to public health. It assumed we will catch up and be able to be participants in this information exchange. Well, that's going to take retooling of our processes. It's going to infuse itself into many of your programs. It's calling out for a critical look at how do we examine each of our programs and see where the information part of that program is going to be changed because of this drive to exchange information. Health information exchanges are far from workable yet. There isn't even a solid business model behind them. But they're being pushed. And new models are cropping up. This is one of those things that comes back to that theme. The times they are changing, and those times are going to change your programs. I'm going to go through a few pictures of very recent covers of industry magazines. This one's from Information Week. It says from CRM to social. CRM is customer resource management to social, meaning social media. Basically, this is on the Information Week. So for the information systems people of the world and in business, they're struggling with this notion of how do you deal with social media? So when we talk about big data, social media are means by which the big data are happening. And so I'm going to get to that in just a moment. But the issue is here, how do you know your customers? How do you know your citizens? How do you know the public you serve? Can your agency work with social media data? Does your agency have a social media presence? How many of you know whether or not your health department has a Twitter or Facebook? Yeah, right? How active is it? Are you using those data for interactions with the community? Yep. Are you pulling those data now to look at them and help you? Good. This is one of those drivers, right? This wasn't in your budget 5 years ago, I'll bet. You've had to re-swizzle things to accommodate for it, but it's a driver to change. This cover from this week's Health Data Management magazine, new pressures, new partners. Again, I think of public health. As we get to more electronic data, we've got new partners in a new way. My institute spends a lot of time working with health departments, with ASTO, with NACHO, with CSTE, with CDC programs on and around issues of data exchange, but invariably those involve new partnerships. So I would say to those of you here, as part of the quality improvement movement, you are actually probably among the best at mastering the notion of what it takes to understand relationships and work process, business process, that is fundamental to making the shift to working differently with new partners. We don't have a choice about a lot of this because the technologies are inflicting change on our society and changes on our partners. And those changes flow back to us. So my contention is, in this exchange of information, as we become more and more automated, as we become more of an electronic handshake with partners, that changes each of your different programs. And public health is such a many-splendored thing, you know, with so many different kinds of programs. You lose a little bit talking generically. If we were talking about just immunization programs or infectious disease programs or chronic disease programs or environmental programs, we could get specific. But just suffice to say, I think we have new partners. The landscape is going to change that. The healthcare landscape with accountable care organizations, I think, creates a completely different kind of partner for us to think about. Now let's take also another force in these times they are a-changing, electronic health record systems. This is a cover from Health Data Management a year ago. And can you read those, what's down there in orange and yellow? I hope this is readable, legible at the back. It says, warning, this product may cause serious patient harm and even death if used incorrectly. And the other one says, please consult with the IT department and/or physician staff to ensure correct usage. Now, let me tell you something. In a survey that just came out from PHII very recently, interviewing physicians who've now adopted electronic health record systems, over 60% said they don't like it. They feel it adds cost to their practice and makes them less effective. Why are we doing this? Is this a move towards quality? Is this going to help the triple aim? Are we going to improve patient satisfaction? Are we going to reduce costs? Are we going to improve quality of care? That's an open question, friends. But guess what? When I started working with, when I left CDC and went to work in clinical health information, corporate world for one of the big companies, maybe 5% of hospitals in this country were automated at what we would have called our top tier, fully integrated level. So that was mid-90s. Now, almost all hospitals are at least automated thoroughly at all the department levels, and almost, probably 80%, I don't have accurate current data, but are really automated at an integrated institutional level, and probably half nationally are integrated systems of health. You look at Kaiser Permanente, nationally, one electronic record system, Epic, universally across all Kaiser nationally. Powerful database. They can do population health like nobody else can do now. But for a lot of folks, these tools, these electronic health record systems, are a curse right now. Because honestly, they don't necessarily improve process, make it more efficient. They impinge on providers because they weren't designed to help the provider of care. They were designed to help people like I used to be, the hospital administrator. I knew my return on investment when I didn't get sued as much because I had fewer medical misadventures. Or when I got higher profitability out of my laboratory because I got greater throughput. So measured through the departmental lens, if I could run more people through, I'm going to make more money. So for the laboratory, for the radiology, for the pharmacy, boy, this was good stuff. Now stick it in front of the practicing doctor, it's like you put a giant load on his or her back and said, become effective with this new tool. Doesn't work. So we've got a generation of improvement to do there. But come back, the times they are changing for public health. The data of medicine, medical care is being automated. Where are you going to get your surveillance data that needs to come from the clinical world? It's going to come from an electronic database. How are you going to get it? What's that going to do to change the processes of your programs? We're all struggling with this. The times they are changing, consumer-directed care. Can you watch television these days and not have an ad from a drug company telling you you need to buy a very specific drug to fix one of your ailments? At least the shows I watch, and maybe it just shows I'm old and they've got my ticket, right? But I'm just so tired of being fed drug ads. Why are they doing that? Because they want me to go to the doctor and say, I need this very specific pill. What does that do to population health? What does the consumer taking some of their own care into their own hands, right? Where do people go first when they start to get sick? You ever heard of Google Flu Trends? Right? What is Google Flu Trends? It's click data, right? It's not medical, it's click data. That's big data at work. They're harvesting every second who's looking for what. Think about the massive computational power these guys have. They can actually watch who's clicking on symptoms of flu, who's clicking on where is a pharmacy, clicking about different parts of what I'm looking for at that pharmacy. Google Flu Trends came about because they asked themselves, does click behavior tell us something about people's health? And then as they put that click data together, they were able to time series it against actual past flu data, and they start saying, wait, well, look at this. Looks like it's very highly correlated, but we can predict 2 weeks ahead of what the public health guys can do. That's kind of scary, isn't it? What's our job? Is our job supposed to be the authoritative source to tell the public this is the shape of the flu season? Or are they going to go to Google? Kind of up in the air right now. I think this is one of those new partnerships we need to start to think about. Who are we exchanging data with? Who are we working with? Are we really in control of that information source? I don't have answers, but I'm just telling you, these are very interesting questions. The times they are changing. Big data. So, I'm really compelled to ask this, since all we talk about these days is big data. Would anyone in here like to define it? Does anybody feel good about raising their hand on that one? Well, let me ask a different question. Are any of you doing big data? I had a friend say, we're doing small data. We're trying to harvest our community's data and make sense out of it and do something with it. That's kind of big data brought local. What is big data? Well, it's a lot of things, but it's a problem. Notice this Computer World cover. This was this week's Computer World magazine, Big Data Blues. Now, the blues means it comes from all the complications of what you do with data. And look at the NSA. They've got the big data blues right now. But hey, again, our data as individuals is out there. It's being used, and it has been for years. But now we have computing technologies that are way different. Most of you know something about relational databases, right? Throw that away. That's now a liability. If you've got massive parallel computing capability and massive storage, data storage capability, and I mean really massive, there are now technologies where you can take this stuff, splatter it all over, and find what you want and put it together in new ways. That's what big data is really about. It's finding new, it's what, when I was a graduate student, we called data dredging. And as a statistician, really worries me, because just because I can find some associations, do they mean anything? Everybody in this room has had probably enough epidemiology, and some of you are probably very experienced epidemiologists, to have that worry you. I once did a paper on associating sunspots with flu. This is an amazing correlation. I don't have a clue if there's any causal relationship, but there is a statistical one. Now, if I get a lot of big data together, a lot of data, I can come up with all sorts of stuff. Well, let me ask you this. As public health, are we going to be caught in the position of responding to others in the business sector who come up with a new pronouncement? We have found the following thing, and therefore you need to go buy product X? And then we could say what? Well, was there a clinical trial behind that? No, just big data. What's the evidence behind what you're recommending? Big data. Got it all answered. I think that puts us in public health in a very curious place, but it's something I think we have to grapple with. The times, they're changing. So I have some friends at CDC who came up with this about big data, and I want to pass this along because I think it is a way to think about it. There are what they refer to as the 5 V's: variety, the sources, the formats, the types, the structures. We should be thinking about that in terms of when we talk about data. The velocity, so the creation, the generation, the transmission, the computation, the speed at which we can gather and analyze data. The volume of it, the pure storage or issues and retrieval related to big data. These are issues that we in public health will have to grapple with. And then, of course, the veracity of it. Are the data that we can get our hands on and that others can get their hands on data that matter? Do they tell us anything that's valid? And finally, the voids. What don't they tell us? Part of the public health challenge, I think, with big data is that the perception by the public that it tells us something, or anybody who comes forward with a pronouncement, that we've analyzed lots of data and we can reach a following conclusion, that conclusion is really valid, that it's not overlooking some holes. So when we talk about health disparities, will the world of big data in health do anything about health disparities? Probably not, because most of that data is going to come from people who got care. Is there any money to be made in telling us who doesn't get care and who doesn't have any money? Not a lot. So I think we in public health have a mission here in the era of big data, and that is to not lose the focus on what our mission is really about. And the 5 V's are one way to think about big data. So when big data conclusions come out, we should be thinking about it this way. All right, so what have we been doing? We have been doing this. We in public health have been building web query systems to make it possible for people to query our data sets. These are just logos from various state public health web-based data query systems. You'll recognize maybe some of those logos. This is kind of an old slide I've used before, but the point I want to make is that our approach has been slow data. Our approach has been we will nurture, curate our data sets, and the more progressive have been able to put them up on a queryable site. I would like to ask you, when you think about quality improvement, to ask yourself, you know, as you go through a process redesign thinking, that you start to ask and challenge how we go about making information artifacts. Would it be better that we put our data out there so that the big providers like Google can get access to it, crawl through it, and make sense out of it? Or should we keep it nurtured, curated, to where we can assure that you, the citizen, only give you the answer that we want you to have? I'm not telling you I have an absolute answer to my question, but it is a challenge, because I don't know any citizen who, when they ask about, gee whiz, what is the infant mortality rate in Memphis, is going to go and start going through the Tennessee Health Department website looking for a query system, or look for the Memphis Health Department to try to find, do they have a query system? Do they have that data set? Do they have that answer? No. They're going to go to Google, to Bing, to ask. They're going to go to a search engine and say, hey, what's the mortality rate here? So is our job now to make our data more accessible to those who can crawl it and use it? Should we be investing